your introduction. And I must thank SLCOG for inviting to talk on a very interesting topic. Pregnancy in patients with pre-existing kidney disease, obstetrician's perspective. We know chronic kidney disease is upcoming phenomenon, but in pregnancy we see it not that often. It affects about less than 1% of pregnancies. But when it happens, we are usually in trouble, and we always seek advice from our nephrology colleagues. So when it comes to a woman with pre-existing kidney disease, as obstetrician, these are some of the thoughts that go through my head. It increases the risk of pregnancy complications, and it sometimes at certain degrees of kidney diseases deteriorate the renal functions, and it deteriorates faster than in when they are not pregnant. Then we need to think of fluid and electrolyte management, because physiological changes in pregnancy also going to affect the electrolyte balance, water retention and all. And then of course the fetal problems like fetal growth restriction. We need to look out for those things. And it increases the risk of infection. Of course, there are on a lot of medication which we are not familiar with, and then we need to consider altering these medications. And if we look at from the patient's point of view, which is who is the most important person, and when you get into her shoes and see, it must be a huge psychological impact on her life, because pregnancy may be a joyful situation for most women. And once they know that they have a kidney disease which can get aggravated, and then they are pregnant, and this may be the last chance that they have to have a baby. So those are the things that we need to consider from obstetrician's point of view. And of course, on top of that, the savior comes from multidisciplinary team, as Ranga stressed upon many times. Okay, the renal physiology has been gone through in many times during this forum, and we know renal blood flow increases because of the cardiovascular changes, and glomerular filtration rate increases, and serum creatinine decreases by 20%. Now this fact is important when we are managing. Even with kidney disease, chronic kidney disease, the ideally if she is going through a good phase of pregnancy, this decrease in serum creatinine should be seen. And if they are not coming down, then it may be an indicator of not so good prognosis. So what are the impacts of pregnancy on maternal chronic kidney disease? We know it depends on the severity of the disease. If you look at the early kidney diseases, then there may not be much deterioration during pregnancy. But however, when it comes to CKD stage 3 to 5, 3B to 5, they can deteriorate faster during pregnancy. If you look at the latter part of these things, the loss of more than 25% of renal function occurs in advanced kidney diseases. And this during pregnancy, they can deteriorate when you compare to non-pregnant state, which might take 3 to 5 years to deteriorate, but they can deteriorate faster. So that's one aspect as obstetrician we need to keep in our head. Okay. And what are the factors that would affect the pregnancy outcomes of the disease? We know it increases the risk of miscarriages, causes preeclampsia, fetal growth restriction, preterm delivery, and fetal death. And this is also going to be aggravated by usual presence of proteinuria and hypertension. And if you see this graph, we know not just the renal function, presence of hypertension also going to increase the poor outcome of pregnancy. Okay, so what can we do as obstetricians? We need to go through the multidisciplinary team, but we need to care them as a primary caregiver, like first contact usually, and then only everything starts. So where should we start the care? I'm going to start with the pre-pregnancy or before pregnancy, because that's very important, and the things that we do during pre-pregnancy also similar to early pregnancy interventions. As Ranga said, pre-existing kidney disease is not a contraindication for pregnancy, but certain limits should be there. And this needs to be considered after detailed discussion with the patient. During previous speakers, we heard that they are unlikely to get pregnant when there is severe kidney disease. However, having said that, they get pregnant when the circumstances are not more suitable. That is the problem. So we need to consider giving contraception. If you feel that a woman with kidney disease is not suitable to get pregnant, she deserves contraception, which includes progesterone-only pills, progesterone-only preparations like dipomidroxyprogesterone or levonorgestrel, intrauterine systems, and of course this cheap instrument called intrauterine copper device can be used in these women. If you consider the consequence of getting pregnant or these women, any form of contraception may be better than not having contraception at all. So even combined oral contraceptive pills can be used, provided that you know that it increases the DVT risk, especially when they are having proteinuria. But progesterone-only methods and intrauterine systems are preferred methods of contraception. And of course, emergency contraception in emergency. All these methods can be used in women with pre-existing kidney diseases. Okay, pre-pregnancy counseling is important, and this needs to be assessed individually when you are counseling a woman for pregnancy, because you can't generalize conditions across all females. We need to consider the severity of the disease, the type of disease, and the presence of hypertension, proteinuria, and the drugs she is on, and then you individualize the care for this woman and individualize the risk category. We always need to consider changing the medication to a safer medication, and Ranga went through a lot of safe medication and unsafe medication. And this is true for even when you are managing a woman in the first pregnancy. And of course, vaccination, because we know chronic kidney disease increase the risk of infection, especially we know respiratory diseases like influenza vaccines can be given even during the early part of pregnancy. And of course, folic acid and low dose aspirin is a important thing, especially low dose aspirin is started in the first trimester, at least by 16 weeks onwards. Again, this is a list of medication that we can and we may not use during pregnancy, and it's there. If you are not sure about any medication, we are free to go and search for it when it comes to managing your patient. Okay. So, as I discussed, care for these women from obstetrician point of view, it's always multidisciplinary. But we need to get them down early. That is a key thing. And then we need to assess their baseline level, and then we need to optimize their control of the blood pressure, and then we can start them on aspirin early, because if we miss this opportunity, then there won't be any benefit of starting aspirin. Kidney functions, we need to look at depending on the severity. In next slide, I will take you through how we can, I'll give you a little guideline on how to assess their renal functions. And of course, we need to assess the fetus by doing serial ultrasound growth scans, at least starting by 24 to 28 weeks onwards. And thromboprophylaxis, as Ranga mentioned, we can start them on low molecular weight heparin to prevent DVT, especially when they are having proteinuria of nephrotic range or even lower with additional risk factors for them. Okay, how we should plan for renal functions apart from the multidisciplinary input? Usually, if their kidney disease is in the early phase, then we can do serum creatinine and urea each trimester because they are very unlikely to deteriorate their function in the early stages. But when it comes to stage 3 to 5, then we need to assess their renal functions regularly. And of course, blood pressure, which we routinely do in all women in pregnancy, but here we need to frequently check them, and of course we can advise them to check their blood pressure even at home. Elevation of blood pressure before 20th week is more likely to be due to their renal disease, but when it starts to happen after 20th week, then we need to be careful whether they are going towards preeclampsia, because that is a risk factor that they carry throughout their pregnancy. And then the target blood pressure here, there was a controversy over the blood pressure level. Here there's two different things. Blood pressure due to chronic kidney disease is because of renal problem, and blood pressure due to preeclampsia is due to placental issue. So the cutoff values vary, and we had a chat even before coming here. Nephrologists would prefer to keep blood pressure level around 140 over 90 here, but when it comes to your suspect preeclampsia, we prefer to keep it below 135 over 85. I think two different pathologies. Sometimes we are in confusion whether this is due to preeclampsia or chronic kidney disease. Ultrasound scan of the renal tract may not give you additional information. However, it's better to have a baseline ultrasound scan of the genital tract, especially if you are looking at obstructive uropathy. Then the management would be different, and that those information can be gathered by doing this. What about the hemoglobin level? We usually do hemoglobin level in general patients at booking, and somewhere around 28 weeks and 36 weeks to make sure they are not anemic. Here they are more prone to anemia. So we do at booking and frequent hemoglobin levels at least 4 weekly, and see if they are deficient in iron, we can supplement with iron, but if they are not responding properly, we need to think of giving erythropoietin here. Proteinuria. So this is another aspect that we face as obstetricians in pre-existing conditions. Proteinuria can be the only sign that we find in to find a woman when it comes to pregnancy with kidney injury. So at least if you look at this graph, if you see a woman with type 2 diabetes, chronic hypertension, or any woman with even marginally elevated creatinine level, it's good practice to perform a quantitative analysis of the urine, at least by UPCR or 24-hour protein assessment, which I also agree with Ranga. It is absolute when it comes to obstetrics, because sometimes we don't have that 24 hours to manage the patient. But it's good practice to see whether there is proteinuria in these patients. That will indicate, okay, with this disease, she is having kidney disease, and that triggers further evaluation. Proteinuria before 20 weeks is, from our point of view, it's okay, because it's not preeclampsia, which have a total different management when it comes to handling the patient, but it may be an indicator of kidney disease. And we know preeclampsia occurs in about 40% of women with advanced chronic kidney disease, so that's why this aspirin is important to prevent that. Okay, let's go back to come back to lupus nephritis. We know, as Ranga mentioned, if they are SLE with lupus nephritis, they are in remission, we are not worried, but the flare can happen even in pregnancy. And unfortunately, most of the flares comes in the second trimester. So when it happens, they come with proteinuria, elevated blood pressure, and urinary sediments. So this mimic, again, pregnancy-induced hypertension and its complications. Differentiation, again, it's difficult. Similarly, when a chronic kidney disease patient deteriorating with proteinuria and elevated blood pressure, creatinine going up, it's so difficult to differentiate whether this is preeclampsia or kidney disease, here is also the same. But however, we see like in gestation hypertension, creatinine increase is less likely compared to renal disease. So that's one clue that we clinically assess. And then of course the C3, C4 levels and rising titer of anti-dsDNA levels. Those things can be used to come to a clinical diagnosis, but it is very individualized and it's a collective decision with the nephrologist. And the management of lupus nephritis is totally different to preeclampsia, because when it comes to early pregnancy, mid-pregnancy, the fetus comes very important, because fetus is not mature enough to deliver. But if you make a mistake saying that this is severe preeclampsia, then you might compel to deliver that preterm baby, which may cause a lot of adverse outcomes. So if you clinically decide together with the nephrologist and the physician, if you decide it properly, then we might improve the pregnancy outcome. Okay, timing of delivery for pre-existing kidney disease, it all depends. Again, it's a individualized decision. There is no one clear rule. If you see a woman who is having deteriorating renal functions, elevating blood pressure, then you might need to consider deliver early. But however, if a woman is having chronic kidney disease but she is stable totally, then there is no indication for us to go and do an intervention early, so that we can wait even up to 40 weeks of gestation. Even as for termination, one thing that I need to add to Ranga's description of when to terminate a pregnancy, in Sri Lanka, there is no indication to terminate a pregnancy because of the fetal reasons, like fetotoxic drug is used, because it's not yet in the books. So, but of course, when there is a risk to the maternal life, then we need to consider delivery. Again, it's not that simple, because that woman may be having her last opportunity to continue that pregnancy. So we need to always have a multidisciplinary thoughts, talk to the patient, get the team together, and then discuss. And of course, we need to get the involvement of that patient to decide on what is best for her. It's not us to decide what is good and what is bad for the patient. When it comes to postpartum care and when it comes to kidney disease and pregnancy, we need to discuss. We encourage breastfeeding. Of course, then the drugs needs to be changed which are suitable for breastfeeding. And we need to discuss contraception here again, which we discussed before. And most of the contraceptive methods are suitable, but of course, you need to, if you keep aside estrogen containing contraceptive methods, better in general, but most of the things are good, and IUCD is a very good option again here. And then you need to arrange follow-up to make sure that they are not deteriorating afterwards, because pregnancy can deteriorate the renal disease itself. Those are the things that I wanted to give it to you from obstetrician point of view. I'm happy to answer any questions if you have at the end of this session. Thank you.